Good morning, everyone. It's David Hurl, chairman of the MHIF Education Committee, and I wanted to welcome you to our spring semester of Grand Rounds. Today is MLK Day, so happy everyone. But it feels a lot like Groundhog Day. Now, why do I say that? It's because basically we're virtual again. But fortunately, we've been virtual for the last few years. We all know how to do it. And so hopefully we have no problem kind of kicking it off again today with no in-person attendance. We're going to continue that throughout January, and then we'll reassess and we'll go from there. But thanks everyone for participating today. I wanted to make a special thank you to our sponsors today. Laura Elm is with us from Pfizer, and also Jane Hutchins from Knitska. Both of those have links on your invitation for Grand Rounds today, and I encourage you to visit with them. Without further ado, I'll have Dr. Cavalcanti introduce our speaker today. And I just wanted to finally mention that we do have a few openings left for this semester. So if you have some great ideas for Grand Rounds, please let us know, and we'd love to accommodate you. All right, without further ado, Dr. Cavalcanti.
Thank you so much, David, and congratulations for such a successful first half of the Grand Rounds. It's fun to be back, even though virtually. And it's a great pleasure to introduce my good friend and colleague, now at Minneapolis Heart Institute, Dr. Erik Schelbert. Erik came from the University of Pittsburgh, and prior to joining us here at Minneapolis Heart Institute at United, he had been associate professor with tenure at the University of Pittsburgh, where we worked for 6 years. Erik has devoted the field and has really developed this very interesting biomarker. If you have not heard about myocardial extracellular volume fraction, ECV for short, you're going to hear a lot about it and how that has become not only an important risk stratification tool, but also potential treatment target for many therapies. Erik has published incredibly, in this field in the cardiac MRI, and we're really fortunate to have him there. He's an associate editor at JAMA, and reviewer for circulation, jet cardiology, and we'll be presenting today on myocardial fibrosis as a therapeutic target. Erik, the floor is yours. Thank you.
All right. Thanks very much for the introduction, Dr. Cavalcanti, and it's great to work with you again. And it's great to be at the Minneapolis Heart Institute among such incredible peers. So thanks for everyone. Click share. This button. All right. All right, great. Well, thanks for everyone for rolling out of bed and attending this early Monday morning. The title of my talk is Myocardial Fibrosis as a Therapeutic Target. And trying to advance the slide here. The arrow button or a... Okay. All right. These are some of my disclosures. I'm on the scientific advisory board for Hiya Therapeutics and also a consultant for PureTech, and I've received grant support in the past. So just a little bit of background. The heart failure epidemic still continues to increase in prevalence. It's obviously very costly and it remains incompletely understood. We lack really efficacious therapeutics, and the heart failure epidemic is not simply the sequelae of coronary disease with huge infarcts. So there's a large non-ischemic component that drives the epidemic. And we're so used to kind of conceptually homogenizing the myocardium, looking at echocardiograms and nuclear scans, looking at the ejection fraction. And I think we really need to kind of revisit the way we think about the myocardium and divide it into its constituents, which is basically the cardiomyocyte, the interstitium, which is regulated by the fibroblast, and also the microvasculature. So what is vulnerable remodeling? Among myriad changes in the myocardium, what are the key components that really matter? And I think we need to sort of reconceptualize how we address these topics and what causes perturbations in the myocardium and what are the effects. So I'm going to focus on myocardial fibrosis, and I will pose to you that the heart may be like other organs, like the lung, the liver, the kidney, where fibrosis leads to disruption of the architecture in the organ and leads to organ dysfunction and ultimately vulnerability to the patient. And you can kind of think about myocardial fibrosis as sort of amyloid light, where you have excess protein in the interstitium, although to a much lesser degree than cardiac amyloidosis. So our job is to take care of people, and when I was at Pittsburgh, we basically tried to enroll everyone that came into, through the cardiac MR scanner into a registry with their permission, and we followed them over time. And I think there's a great quote by Lord Kelvin of temperature fame, and let me just read it to you because I think it's really relevant and it sort of summarizes where we are in cardiology. When you can measure what you're speaking about and summarize it in numbers, you know something about it. And when you can't express it in numbers, your knowledge is meager and unsatisfactory. So we now have tools to measure myocardial fibrosis and also amyloidosis, and we can track therapeutic responses over time with ECV, as Dr. Cavalcante mentioned. So this right here, these are ECV maps, and so this is a pixel-wise map of the human myocardial interstitium. So on the left, we see a lot of interstitial expansion. We also see heterogeneity of that diffuse interstitial expansion, and the ECV is 38%. On the right, we have a normal interstitium, which includes the microvasculature, notably, and we have a normal ECV at 22%. Typically around 29%, 30% or above is considered abnormal. And we can basically now detect myocardial fibrosis, particularly when it's diffuse, that we can't pick up with late gadolinium enhancement, of which I think most of us are now pretty much familiar. And so we can basically quantify disease in the myocardium, whether it's diffuse or focal, with this new technology of ECV maps. And so just in case people get cut off and need to go to clinic or whatever, if I run over, I thought I'd just kind of give some of my conclusion slides early on at the beginning and sort of foreshadow what I was going to talk about. So interstitial expansion for myocardial fibrosis causes mechanical disruption, mainly diastolic dysfunction, and systolic function measured by ejection fraction or global longitudinal strain are mostly independent of one another. It causes microvascular dysfunction with decreased perfusion reserve, capillary rarefaction, and also electrical dysfunction by perturbing the myocardial electrical homogeneity of the myocardium. And these issues increase the risks of death and hospitalization for heart failure and also arrhythmia. And ECV has a similar strength of association with adverse outcomes as ejection fraction or global longitudinal strain, and this sort of reemphasizes its likely causal role to mediate these adverse outcomes. And cardiac MR and also cardiac CT can now measure interstitial expansion with extracellular volume measures reliably. And now we're entering the era where we're going to have potent antifibrotic therapies, which are currently under development and promise to reverse the cardiac dysfunction that ensues and ultimately improve outcomes and regress the epidemic of heart failure that we typically confront on a day-to-day basis. And we now have a tool to measure myocardial fibrosis serially, and we can track disease progression or regression in response to therapy. So this is the conceptual model that sort of summarizes well over a decade of research. So on the Venn diagram on the left, the cardiomyocyte, we measure its dysfunction with contractility, ejection fraction, and global longitudinal strain. And on the right, we have the fibroblast, which manages the cardiac interstitium and leads to myocardial fibrosis. And perturbations in either one of these two domains of cardiac vulnerability can lead to cardiac outcomes. And interestingly, one is not a surrogate from the other. They're correlated statistically, but it's such a small degree that clinically it's almost irrelevant. And this work was fostered by great input from my colleagues Miho Fukui and Joao Cavalcante, who helped a lot when we were working together at the University of Pittsburgh. And so now we have the potential to reverse fibrosis with intervention and sort of reverse this clinical progression that ultimately leads to adverse outcomes in patients. And typically we can do this with renin-angiotensin and aldosterone inhibitors, but those agents are relatively modest in their efficacy and other agents are in development. So now there are over 30 phase 2 trials that are mostly observational, but also some interventional that leverage change in ECV as an endpoint. Excuse me. The last time I queried the clinicaltrials.gov database, and to really understand what's going on here, I think it's useful to look at the histopathology, and these images are sort of what got me interested in the whole field in the first place. Extracellular matrix expansion from diffuse fibrosis appears ubiquitous in a variety of different disease states, and it leads to distortion of the microarchitecture. So on the left, we have a control where we see bundles of cardiomyocytes separated by relatively small amounts of collagen, which makes the stroma of the myocardium. And then in dilated cardiomyopathy, we can see this diffuse expansion of the interstitium. And one has to wonder if the energetics are normal in cardiomyocytes that are sort of embedded in this morass of collagen. And similarly, when we look at remote myocardium and ischemic cardiomyopathy far away from the infarct, we can see the same process here in end-stage ischemic heart disease. Obviously, these are postmortem samples from humans, which were published in the 90s. And here's a close-up shot, showing cardiomyocytes embedded, sort of mummified in excess extracellular matrix, which is mainly composed of collagen, mainly type 1, but also type 3. And these are beautiful pictures of what the interstitium is supposed to look like. This is when we digest away the cardiomyocytes with potassium hydroxide. And this is the normal extracellular matrix. And in hypertensive heart disease, as left ventricular hypertrophy increases, we also have expansion of the interstitium, pathologic expansion of the interstitium, where we can see this just thickening of the spaces between cells in advanced hypertensive heart disease. And this is only worsened when there's diabetes, and histologically it can sort of mimic cirrhosis in the liver when we have bridging bands of myocardial fibrosis. And so there's several mechanisms in which myocardial fibrosis can lead to vulnerability to our patients. Capillary rarefaction is typically observed, meaning less capillary density. And perivascular fibrosis can limit the perfusion reserve. Also, the increased space between the capillary and the cardiomyocyte increases the diffusion for oxygen, or the distance for oxygen to diffuse to get to the cell. And it makes the cardiomyocyte prone to hypoxia, can trigger apoptosis, and promote progressive myocardial fibrosis with further loss of cardiomyocytes, which are ultimately replaced with fibrosis. And the type 1 collagen in myocardial fibrosis has a tensile strength of steel, and so this can lead to stiffening of the myocardium and lead to diastolic dysfunction. And these are just some of the references to kind of back up these claims, but ultimately leads to increased filling pressures. And so the other interesting attribute of myocardial fibrosis is that it perturbs the electrical conduction, the electrical homogeneity. Electrical impulses can't go around bands of collagen, and so we can get slow pathways and substrate for reentry. And of course, all of these insults to the myocardium can culminate in adverse outcomes and lead to cardiomyocyte dysfunction, organ dysfunction, and ultimately adverse clinical events. And I think focal replacement fibrosis is typically felt to be irreversible, but diffuse myocardial fibrosis is reversible and is amenable to pharmacologic interventions as well. And this is a nice paper, just sort of a proof of concept paper in a preclinical model in rodents where they caused diffuse myocardial fibrosis, and they were able to reverse it with this matricellular protein, sort of a proof of concept. And there's many other studies that show that in preclinical models, but what's really interesting is that we now observe this in humans as well. So there's 4 human histology studies in which They biopsied human myocardium serially over a time period of 6 to 12 months. This is the first paper showing that lisinopril regresses myocardial fibrosis and leads to improvement in left ventricular diastolic dysfunction. Same thing with losartan and also with spironolactone. This also could cause regression of myocardial fibrosis, and then also ACE inhibitors, in this case with perindopril and hypertensive heart disease. These can be summarized here. But what's interesting is that the absolute regression is so modest. I mean, it's really 1% of the absolute, 1% absolute change of myocardial fibrosis. So we definitely need stronger agents to treat myocardial fibrosis that is so ubiquitous clinically. And just a few more interesting studies looking at human myocardium. This study from Van Heerbeek and colleagues showed that the amount of fibrosis was similar between HFpEF and HFrEF, heart failure with reduced or preserved ejection fraction. And it was also important, which is relevant to our clinical population here, patients with who are on VADs, ventricular assist devices, the more fibrosis, the less likely they were to recover. And so, clearly myocardial fibrosis is ubiquitous, found in response to a variety of clinical stimuli. And so what do we do? So how do we investigate this clinically? So now we have extracellular volume fraction. Let me just back up a little bit. This is typically called T1 mapping in the field. This is essentially a T1 recovery curve, and essentially what happens is the protons invert, not to get too technical here with the radiofrequency pulse, and then they recover, and the recovery is governed by an exponential. So we can take snapshots over time, fit that curve, and compute what the exponential is. And that change in the exponential before and after contrast is linearly related to how much gadolinium accumulates in the myocardium. And so we're simply using it as an extracellular space marker. We can do the same thing with cardiac CT using iodinated contrast. Both that and gadolinium contrast are extracellular contrast agents. And the more fibrosis there is, the more uptake there is relative to plasma. And so the uptake relative to what's in the plasma is essentially what the extracellular volume fraction is. And so clinically with cardiac MR, we get T1 maps before and after contrast. We can co-register the images, and we measure whole blood, but we need to compute what the concentration is in plasma to basically compute extracellular volume fraction. We can do this on a pixel-wise basis with the resultant ECV map below. And let me just show you how powerful this technique is. So on the top, we have a patient with sleep apnea, and we see right here this small little focus of focal fibrosis. We also see this here in the late gadolinium enhancement imaging. But there's no fibrosis elsewhere aside from the RV insertion point in the inferior septum. However, in this patient with heart failure, we see the same thing, a small little focus of myocardial fibrosis, but looking at the ECV map, we see severe diffuse myocardial fibrosis. And so these patients look the same with older techniques, but when we actually look at the interstitium, they're radically different. And I would pose to you that their risks are also very different as well. Extracellular volume fraction is extensively validated in people against the collagen volume fraction. Here are some of the studies. There's been more. There's too many to fit into one slide. Excellent correlations with histology, with R-squareds, up to 0.9 with whole heart measurements. And this is despite sample error with needle biopsies. So myocardial fibrosis, even though it's diffuse, is not homogeneous. And there's a huge coefficient of variation when we do endomyocardial biopsies, simply because the diffuse fibrosis is not evenly distributed throughout the myocardium. And this is one excellent paper by Schwarz and colleagues showing this. The coefficient of variation was 43%, which is pretty darn high for measuring myocardial fibrosis with endomyocardial biopsies. And so, and this is similar to what we see in HCM. So we typically see that the fibrosis is not diffuse throughout the myocardium, even though every single cell in the heart carries the same genotype. We see the same thing in amyloidosis, where it's sort of not homogeneously diffuse in its distribution throughout the myocardium. So let's look at some clinical conditions with extracellular volume fraction measurements. So let's focus on HFpEF. The first paper that I'm aware of was by Rommel and colleagues. And this is really seminal work where they examined the role of myocardial fibrosis measured with extracellular volume fraction, and they also did pressure volume loops to measure the end diastolic pressure volume relationship, so sort of the invasive gold standard of myocardial stiffness. And they found a beautiful linear correlation with the stiffness constant, the beta for the exponential fit to the end diastolic pressure volume relationship curve. And they correlated that with the extracellular volume fraction, which makes perfect sense when you think about it, given how stiff collagen makes the myocardium. Others have sort of measured the stiffness, and type 1 collagen has the tensile strength of steel, according to a paper from the early 90s. And interestingly, ECV predicted diastolic dysfunction better than echocardiography, which was felt to be too load dependent. And in multivariable regression models, echocardiographic parameters didn't remain associated statistically. And Julia Mascherbauer's group in Austria also looked at outcomes in HFpEF with extracellular volume fraction, and also found that those with higher ECV were more vulnerable and had worse outcomes over time. And in Pittsburgh, we looked at extracellular volume fraction in people who either had HFpEF or were at risk with HFpEF, manifest by preserved ejection fraction and elevated natriuretic peptides. And we found that ECV was expanded in both people with HFpEF or at risk for HFpEF. These are some of the ECV maps from the patient population. So this is normal up here. This is severe diffuse fibrosis, and of course this is cardiac amyloidosis, which is a big confounder, I think, in HFpEF trials if it isn't examined, because of course those people have the worst interstitial expansion and the worst outcomes, and that's shown here. So this blue curve that nosedives down to 0, those are the patients with cardiac amyloidosis that eventually, none of them had event-free survival beyond a little over 2 years. And the outcomes in those either at risk or with HFpEF were similar, and they both had increased extracellular volume fraction. And so this is just a blow up of those curves. So the amyloid patients are the worst of the worst, and there was a dose response where the more fibrosis, the worse the outcomes in HFpEF in a cohort of about over 400 patients. And then looking at aortic stenosis, this is multi-center data led by the group in Glasgow by Mark Dweck and colleagues, and basically compiled patients who were undergoing aortic valve interventions, who had ECV measurements. And remarkably, the range of ECVs were pretty similar across centers. However, native T1 was sort of all over the map, no pun intended. And basically, native T1 is not nearly as a robust a measure of myocardial fibrosis. It's simply susceptible to too many confounders. And they basically found that those with increased fibrosis had worse outcomes even after the valve intervention, showing that the myocardial response to the valve dysfunction is important, extending beyond the valve. And this work was subsequently carried forward by Seung-Pyo Lee, who deployed machine learning to sort of pick out of all the alphabet soup those variables that were most influential in terms of subsequent outcomes in patients. And they basically identified that beyond age, ECV was the biggest predictor of adverse outcomes in terms of their association with mortality. So again, sort of emphasizing how important extracellular volume is, despite all the potential statistical interactions that can happen with observational data. So really seminal work by the group. ECV also occurs in chronic mitral regurgitation. This is a nice paper by Rick Steeds showing that extracellular volume fraction also correlated with with a series of parameters that sort of indicated myocardial disease. And so we basically, at the University of Pittsburgh, tried to measure it in everyone that came through the scanner since 2010, late 2010 specifically, and we're able to basically measure extracellular volume and also global longitudinal strain measures in over 1,500 patients. And interestingly, we found that global longitudinal strain measures were linearly related to left ventricular ejection fraction, but the relationship between global longitudinal strain, which was better associated with outcomes than ejection fraction, the association between global longitudinal strain and extracellular volume fraction was really quite minimal. So the R squared was only 4%, and while this was statistically significant, it's so incredibly weak. It's hard to argue that there's a tight relationship here. It looks like a cloud with a line through it in panel B. And that, I think, is interesting because ultimately, global longitudinal strain and myocardial fibrosis sort of reflect different cell types in the myocardium. Cardiomyocyte function being best measured by global longitudinal strain with MR, and the interstitium, which is essentially fibroblast dysfunction, is best measured with extracellular volume fraction. And here we see nice dose-response relationships for the outcomes of death or heart failure, or death alone, or hospitalization for heart failure in survivors in these panels, both for global longitudinal strain and for extracellular volume fraction. And of course, if one had disease in both of these domains of cardiac vulnerability, outcomes were worse, up to almost 8 years in this paper. And looking at these statistics, the top dog statistically predicting vulnerability to patients were basically measures of contractile dysfunction, ejection fraction, and strain, and then also extracellular volume fraction. And the strength of association is quantified by the chi-squared statistic in Cox regression models, whether it was univariable or multivariable. And this extended to a whole bunch of different subgroups, patients with HFrEF, HFpEF, patients with MI, without MI, with or without diabetes, and this was consistently found. And we're fortunately able to look at all these subgroups and had enough statistical power thanks to the work of Joao and Miho Fukui, who really pulled a lot of weight to analyze these huge numbers of patients. And so again, this is the conceptual model, which reflect the two principal cell types of myocardium, the fibroblast and the cardiomyocyte. Fibroblast dysfunction leads to increased ECV, increased outcomes. Cardiomyocyte dysfunction leads to decreased global longitudinal strain, and again, decreased outcomes. And these two different domains of vulnerability are distinct cell types, and they're relatively distinct from one another. And so, just a sort of a new way to kind of conceptualize the myocardium. ECV is also important in other clinical settings. We looked at those patients who were getting ICDs, and those with higher extracellular volume fractions were more predisposed to get ICD shocks. And this is a small cohort of a little over 200 patients, and we found similar relationships when we looked at the outcome of either shock or anti-tachycardia pacing. This is presented as an abstract form, but is not yet published yet, and this is work thanks to Erik from the Karolinska Institute, who spent 6 months with us a little while ago. And when we looked at ECV in multivariable Cox regression models, ECV remained associated with these electrical outcomes, if you will, independent of other variables in the model. Whereas myocardial infarction and, interestingly, focal myocardial fibrosis on late gadolinium enhancement imaging did not. So once we introduced ECV into the model, MI and focal fibrosis fell out. And so this sort of mimics what's been found in other studies. This is a post-mortem study of a population study out in Oregon, led by Sumit Chugh and colleagues and Balaji Tamarapu, where they looked at sudden cardiac death victims in the community, and they basically found that people who had no other explanation frequently had excess collagen volume fraction at autopsy. Again, re-emphasizing the fact that this can be a vulnerable phenotype that leads to ventricular arrhythmias and a substrate for reentry. Similarly, a paper out of Brazil showed that treatment of diffuse fibrosis with spironolactone could lead to less arrhythmic burden on Holter monitors as well in various cardiomyopathies. And so essentially when there's interstitial expansion for myocardial fibrosis, it can lead to all these perturbations in the myocardium, which leads to clinical adverse events. So just a brief word about how we measure myocardial fibrosis. There's a lot in the literature of measuring it with native T1, which doesn't require contrast, or other metrics, including late gadolinium enhancement, specifically non-ischemic fibrosis. And on the, whatever color this is, salmon, I guess, colored bars, we can see how strongly ECV links with outcomes in univariable models, which is simply blows these other metrics out of the water. And we see the same thing when they're somewhat diluted in multivariable models in the green bars. The strength of association between extracellular volume fraction and outcomes is far stronger than native T1, post-contrast T1, or non-ischemic fibrosis on late gadolinium enhancement imaging. And again, this is a cohort of over 1,500 patients. And again, these are some of the outcomes data between these various metrics. And so ECV, whether it includes focal fibrosis or not, leads to a nice dose-response relationship at different strata of ECV, and we simply don't see that with other metrics of myocardial fibrosis. So the point of all this is that extracellular volume fraction, and particularly the vulnerability associated with it, is best, myocardial fibrosis and the vulnerability associated with it is best measured with extracellular volume fraction. And just some other interesting papers that I wanted to share with you. Among the athletes in the crowd, Peter Swoboda out of Leeds found a nice paper in patients with either athletic heart or hypertrophy from other causes, and was able to demonstrate that as myocardial thickness increased in athletic heart, ECV actually went down because of cardiomyocyte expansion, whereas in pathologic hypertrophy, whether it was hypertrophic cardiomyopathy or other conditions, the extracellular matrix actually went up. So in disease, typically when LVH happens, there's also pathologic expansion of the myocardial interstitium as well. And they did a very clever study where they looked at injured athletes who were sort of forced to detrain because they couldn't basically do their athletic activities anymore, and they were able to show that the cardiomyocyte compartment would regress, and ECV would actually increase a little bit or stay constant. So sort of a nice study in humans showing how the different compartments of the myocardium can respond differently to either pathologic stimuli or adaptive stimuli in the setting of athletic heart. And so what are some of the therapeutics on the horizon? We talked about sort of inhibition of the renin-angiotensin system, and that certainly remains a therapeutic target. But there's also RNA-based therapeutics that are coming down the pike, whether it's microinhibitory RNA or long non-coding RNA, and then there's also pirfenidone, which is a antifibrotic medication that's used in pulmonary fibrosis, which is an oral agent without any hemodynamic effects, even though the mechanisms aren't completely understood. But these are some of the novel therapeutics that are coming down the horizon. Finerenone is very interesting This is a non-steroidal blocker of the mineralocorticoid receptor. So this is an antagonist similar to spironolactone, but it doesn't have all the side effects necessarily. And interestingly, this doesn't lead to hyperkalemia or renal dysfunction. And this is in development. This is a drug that's being developed by Bayer to basically block aldosterone without hyperkalemia or renal dysfunction. And that was a phase 2 trial, I believe. And there's also microRNAs. So Thomas Toom is sort of a leader in this field, and specifically miR-132 has been shown to be a potent antifibrotic. This is a paper, I believe, in Nature, I think, where they had a preclinical model of heart failure that showed quite a bit of efficacy. And then they actually did a phase 1 trial that was published in the European Heart Journal just a little while ago. And they were able to show that this microRNA had a dose-dependent effect, and in people with heart failure with reduced ejection fraction, there was some improvement in ejection fraction, lowering of natriuretic peptides, lowering of fibrosis biomarkers. Unfortunately, they didn't look at extracellular volume fraction measurements, and also shortening of the QRS duration as well, all suggesting an antifibrotic effect leading to reverse remodeling in people. And this should be going into phase 2 trials soon. And this led to the development of a new pharmaceutical company called Cardiology, which appears to be very well funded. And I think we're going to be hearing more about this in the future. There's also long non-coding RNAs. This one in particular, there's one called Whisper that leads to specific anti-fibroblast activity that's specific in the heart, but not apparently in other organs. This led to the formation of another company called Therapeutics, and this company is developing a cardiac-specific anti-fibroblast agent to reverse myocardial fibrosis with high potency without off-target effects. And it's important to remember that collagen is the most ubiquitous protein in the body, and of course we need it to survive. Great cartoon by Gary Larson here from the far side. We don't want to have off-target effects such as aortic aneurysms or Achilles heel ruptures and things like that. We basically want to regress fibrosis in the heart, and only in the heart, and only when it's excessive. And so, pardon for the typo there, one of my colleagues, Chris Miller at the University of Manchester, was able to work with Roche and get pirfenidone and basically performed a phase 2 trial. And he was able to use extracellular volume fraction. Chris Miller has done just phenomenal work in this field. He was the first to look at cardiac explants and measure the collagen volume fraction and correlate it with clinical extracellular volume fraction measures and report an R-squared of 0.9, which is pretty phenomenal work. And here he published his results of his phase 2 trial in Nature Medicine. This was a randomized, double-blinded controlled trial looking at patients with an ejection fraction of 45% or above, so HFpEF, and they had to have interstitial expansion. They had to have an increased ECV of 27% or above to get into the trial, and they were randomized to either receive pirfenidone or placebo, 47 in each group, and he treated them for pretty much a year. And he was able to show that pirfenidone reduced myocardial extracellular volume fraction. The results were somewhat modest, but it was only a year's worth of treatment. Minus 1.2% was the amount of fibrosis regression measured by ECV. And it was generally reasonably well tolerated, not very different from the placebo arm. And the most common side effects for pirfenidone were nausea, insomnia, and rash. And this now sets the stage for phase 3 trials. And importantly, natriuretic peptides also regressed with antifibrotic treatment with pirfenidone. And results were seen in natriuretic peptide reduction by the 13th week of treatment, which was an encouraging sign. And yeah, and so this trial, I think, is sort of a hemodynamically independent way to treat myocardial fibrosis, but it remains to be validated in a phase 3 trial to examine the impact on clinical events. So I think now we're sort of at this new era in cardiology where we now have a way to quantify myocardial fibrosis. And so we can see how both the cardiomyocyte compartment responds and the interstitial compartment responds with pharmacologic interventions or procedural interventions, whether they're percutaneous or surgical. And we can understand now the efficacy of all these interventions on different domains of the myocardium. And it's also important to measure, we can't use advanced imaging to do phase 3 trials. It's simply going to be too expensive and too prohibitive. And without getting too much into unpublished work, there definitely are ways to identify populations with a really high prevalence of myocardial fibrosis. This is work that's in development without reliance of advanced tomographic imaging such as cardiac MR or cardiac CT for phase 3 trials. So I think there's going to be probably a multi-parametric risk score that's going to be developed, and we're actively working on this to basically set the stage to find out exactly which population should be treated with antifibrotic agents without the reliance on cardiac imaging. And so, in conclusion, hopefully I've convinced you that interstitial expansion in myocardium is super bad. It leads to diastolic dysfunction, microvascular dysfunction with decreased perfusion reserve, capillary rarefaction, and also as a substrate for reentry. And these perturbations lead to higher risks of death and hospitalization for heart failure and also arrhythmia. And the prognostic power of extracellular volume fraction is on par with other metrics of contractile dysfunction, which is sort of the main parameter around which so much of cardiology revolves. So it's just about as strong as ejection fraction, global longitudinal strain, and its association with outcomes, yet it's not correlated with those, and one is not a surrogate for the other. And we can now measure this with cardiac MR and also cardiac CT on a routine basis, simply and relatively easily, provided we have the right imaging tools to do that. And now we're in the age where we're having potent antifibrotic therapies, a wide variety of agents with different mechanisms that are under development that promise to reverse cardiac dysfunction, improve outcomes, and sort of regress the epidemic of heart failure that seems to plague our society. And I think it's important to deploy extracellular volume fractions to monitor disease progression or regression of myocardial fibrosis. So these are some of the colleagues that I've had the pleasure to work with over the years in alphabetical order, who really contributed a lot to kind of pushing this field forward. And it's really been a blast working with such outstanding colleagues over the years. So that's all I have for you. Thanks for your attention.
I'll take that, Mike. Erik, that was fantastic talk. I really enjoyed it. It's kind of one of those topics where in cardiology, we all know that it exists, but the work that you've done along with your colleagues has really quantified this data. And like the quote you put in earlier, by having the data, and we now can develop the therapeutics, and it's something that's already being done. So that's fantastic. In the world of echocardiography, we'll say a bit tongue-in-cheek, in young people, their hearts suck. And that's because they have such amazing compliance that they don't really rely on the atrial kick. And yet, as we get older, we know that there's a natural reliance on the atrial kick in order to generate cardiac output. Yeah, I may have missed it, but was there anything in your data that told us more about perhaps the change in ECV and aging?
Yeah, I didn't share that data with you. Friends and colleagues in London, James Moon, who may have given grand rounds here before, sort of looked at healthy individuals across the lifespan and actually found no association with aging per se, presuming that patients were healthy. There probably is an association with age, but it's probably mediated by their comorbidities. So as diabetes and hypertension increases in prevalence with age, I think so too does the myocardial fibrosis. But it's not, I think the good news is that as we all get older, we're not necessarily condemned to myocardial fibrosis simply with the passage of time. I think if we manage our risk factors and all the other things that kind of lead to hypertension, diabetes, we can avoid it. So there certainly is a relationship with age, but it seems to be mediated more by comorbidity rather than aging itself. And so as long as people are healthy, they can dodge that bullet, it appears. One other thing I didn't mention, women apparently seem to have higher ECV than men, and it isn't clear if it's a difference in the vasculature because ECV measures the microvasculature, but there doesn't seem to be a prognostic adverse association with the increased ECV in women. So it probably reflects differences in biology rather than pathophysiology.
Erik, fantastic talk and learn always from you. I was wondering if you could comment on when we do aortic valve replacement, so the aortic stenosis story here, if we wanted to track that myocardial response, there is a confounding factor that it relieves the afterload. There is myocyte regression as well from LVH regression.
Yeah.
So how would you propose us to track that response with the interstitium?
Yeah. So fantastic question, and I think a really savvy question. And this is another reason why I think it's really important to measure ECV and not simply native T1. So in the pirfenidone trial, that's a hemodynamically neutral drug, so there shouldn't be any difference in the cardiomyocyte compartment. It's not like we're unloading the ventricle with antihypertensive therapy. Of course, when we replace a valve, we're completely unloading the ventricle in terms of the afterload. And there most certainly is regression of the cardiomyocytes as the hypertrophy regresses, but there's, I think Krahenbuhl and Hess out of Germany, out of Switzerland, excuse me, kind of did serial human biopsies after aortic valve replacement, I think both for regurgitation and stenosis. And they're able to show that the collagen compartment pretty much stays the same. And one would think that the vulnerability stays the same, and that's sort of what the Mark Dweck paper, the Everett and Dweck paper showed in the European Heart Journal. So to answer the question, we have to carefully measure myocardial mass and the total interstitial compartment, so which would be ECV times the left ventricular mass. And to look at the cardiomyocyte component, it would be 1 minus the ECV, that percentage, times left ventricular mass, and the regression over time. Yeah, that's absolutely critical. I didn't want to get too much into the weeds, but I think when we're looking at interventions that change hemodynamics, that's absolutely critical to follow the response over time. And now we have the tools to do it, so we can basically fractionate, divide the myocardium into the interstitium and the cardiomyocyte compartment and look how they change over time as long as we scale it to left ventricular mass. So we can get the total volume of the interstitium and the total volume of the cardiomyocyte compartment as long as we multiply ECV or 1 minus ECV times left ventricular mass.
Thank you very much, Dr. Schelbert, for that excellent talk. We do have 3 online questions, the first of which comes from Dr. Dirks. And he's asking, have SGLT2 inhibitors been evaluated, and is there any correlation with biomarkers or even diuretic doses?
Yes, there was a recent paper showing a really modest regression. It's a great question with SGLT-I inhibitors of myocardial ECV. I didn't show it, but I forget the exact percentage. It was in JACC cardiovascular imaging, I believe, that did show a modest regression, and that could be one of the mechanisms in which outcomes are clearly improved with that therapy. And what was the rest of the question? I don't recall the other biomarkers if there's an association with it. But that paper is in JACC imaging. I should have shared that with you, but I think I simply overlooked it.
No, I think that was certainly a fair response. And unfortunately, I did lose that question. So Dr. Dirks, if you would like to resubmit the second half of that one, I apologize for that. We do have several other questions. The next comes from Dr. Fukui. So she says, thank you very much for your excellent and informative presentation as always. With the question of, do you think there still will be incremental value of the assessment of native T1 and indexed ECV in addition to ECV? Or the assessment of only ECV is good enough?
I think it in part kind of gets back to Dr. Cavalcante's question. I think it'll be important. So the ECV index is simply measuring it, scaling it by the left ventricular mass index. So I think they're both going to be important. But I think native T1 alone is going to be a mess. Looking for serial changes over time. Diabetes itself can increase native T1 without increased ECV. And so I think it's going to be important to measure ECV itself, but then also the total compartment size of both the cardiomyocytes and the interstitium, both over time. So I think all three will be important.
Excellent. Thank you very much for that. We do just have one more online question that comes from Dr. J. Travers. He says, thank you very much for the excellent talk. And the question is there was a report in the journal Science this week from UPenn where researchers actually used CART therapy to treat myocardial fibrosis. Specifically, they packaged mRNA in lipid nanoparticles similar to the COVID-19 vaccine to target T cells that would attack activated fibroblasts in the heart expressing fibroblast activating protein and remove the fibroblasts and improved LV function in a hypertensive model of myocardial fibrosis. Did you hear about that, and do you have any thoughts on that potential technology?
Yeah, no, I didn't hear about it, and thanks for the tip. But I think anything that changes the secretome, if you will, of the cardiac fibroblast or the myofibroblast, if you will, or simply attacking the myofibroblast directly, I think is going to be a winner in heart failure, or either heart failure treatment or prevention. To me, this is one of the ripest therapeutic targets that we have available to us, and now that we can measure it, we can really understand just how important it is. But I think, that sounds very promising. And so our problem up until this point is that we've simply had such weak therapies. We've essentially only had ACE inhibitors, spironolactone, eplerenone, and angiotensin receptor blockers. So we're very much in need of newer agents that attack, so to speak, the interstitium and the cellular and the molecular drivers that lead to its expansions. But that sounds really promising.
Excellent. Thank you very much. That's all that we had for the online questions.
All right. Thanks for your attention.
Thank you.